So shall I start?
Yeah, please. You first introduce yourself, invite the faculty, thank the CSI for giving you this opportunity to be online, and thank your other postgraduate colleagues from various parts of the country for joining this session, and then start your presentation.
Good morning, everybody. I'm Dr. Manjunath KM, here DM of CSI.
Sir, no, we are unable to hear you, I think.
There is some audio issue, so just check your net. You can put off your video.
No, sir, there is no internet. It's not about internet. So is microphone issue, sir.
Yeah, sometimes if you put off the video, then your audio becomes better.
Manjunath, you can switch off your video, and then your audio will be much better.
Yes.
Actually, I can hear fine.
Now you can start talking. Dr. Manjunath, let's hear you.
Sir, is it okay now?
Yeah, little better,
okay.
but can you increase the volume?
I have put it to maximum, sir.
Okay,
Yeah,
okay,
that's fine.
okay.
But,
Alright.
Then you sit closer to your mic so that your voice will be much more clear, much more audible.
Yes.
it is better to have the video also because his facial expressions, everything is important in discussion.
Yeah, important.
I
But
also
when,
think so.
if there is an internet technical issue, he may be permitted.
Yeah,
without
that's fine. That's fine.
No, I think
Sir, am I audible?
I agree with Sudayakumar because we have to see his expressions. So better that he is on online visible also. And if
Yeah,
there is a
good.
difficulty in hearing,
Yeah,
then
but
we
let him talk at least. Let him talk first.
Okay.
Okay.
Dr. Manjunath,
Yes, sir.
can
I'll
you
start,
start
sir.
the proceeding?
Yes, sir. Good morning, my respected teachers. I am Dr. Manjunath, DM Cardiology Resident from Pushpagiri Institute of Medical Science, Tiruvalla, Kerala. I'm thankful for giving me this opportunity to present in front of great examiners. I welcome you all, sir. Let me start my case presentation. So here I am presenting a case of 53-year-old male hailing from Koyanjeri, Kerala. He studied up to 12th standard and he is a mechanic by occupation. He came with chief complaints of exertional palpitations since 40 years, exertional breathlessness since 30 years. He had underwent wall repair 20 years ago. Increase in breathlessness is 1 week. One episode of nocturnal breathlessness, so 5 days ago, and a fetal edema since 1 week. Coming to the history of presenting illness, his symptoms dates back to 40 years when he started experiencing exertional palpitations while playing with his classmates at school, which was regular palpitations, settles on taking rest. This was not associated with any syncope or near syncopal attacks. Not associated with symptoms like breathlessness, chest pain, or fatigue. So for these complaints, he was taken to a doctor who said that he has a wall leak and may require wall surgery in a later date. He was advised to take penicillin injections once in 3 weeks. About 30 years ago, he started developing exertional breathlessness, which was insidious onset, gradually progressive, while climbing stairs or lifting heavy weights. That was the NIHA class 2 symptoms. However, he got married at the age of 26, that is 28 years ago, and could do normal sexual relationship with his spouse. But after 6 years of his marriage, about 20 years ago, his symptoms deteriorated to NIHA class 3. He was advised wall repair. For this complaints, he consulted a doctor, cardiologist. He was advised wall repair surgery, which he underwent in the year 2000 or 2003. After the surgery, he was advised to discontinue regular penicillin injections, and he does not know why the penicillin injection was stopped. He had temporary improvement in symptoms for the next 2 years after the surgery. However, after the 2 years of surgery, he again started developing symptoms. On consulting the surgeon, he was told that surgery was not successful and he must undergo a redo surgery, most likely a wall replacement. However, he was continued on medications and he had some satisfactory improvement. 6 years ago, again he deteriorated and was planned to do redo surgery. However, the procedure was not done and was asked to continue same management as surgery was carrying a higher risk. He was detected to have a high BP and was given drugs for that, and his BP was brought down to normal during when they said that he was high risk. With this, he became much better, and he was managed with MHA class. He had MHA class 2 most of the time, with occasional deterioration till the last 1 week when he started deteriorating, and he had one episode of paroxysmal nocturnal dyspnea 5 days ago. However, there is no history of irregular palpitations during this paroxysmal nocturnal dyspnea. He also gives history of pedal edema for the past 7 days, which has come down on medications with increased urination after hospitalization. However, there is no history of syncope, no history of hemoptysis, no history of cyanosis, no history of cardiac pain or right hypochondrial pain. He was taking one drug which makes him pass urine, another drug which was given 5 days a week, and some other 2 drugs which will control. He said that it will control his BP and his heart functions. He was very meticulous about his medications. Coming to the past history of joint pains at the age of 7 years and 10 years, and he took Ayurvedic medications and he got relief. So no history of any heart disease at birth. No history, there is history of hypertension. No history of diabetes mellitus. Family history: mother is hypertensive. All other family members are keeping good health. And coming to the personal history, diet is mixed. Sleep is not disturbed. Appetite is good. Bowel and bladder habits are regular, and no habits. So this is the history of our patient. On summarizing the history,
Yes, go ahead.
shall I proceed, sir?
Please
Yes,
do
sir.
summarize, then you will have questions.
53-year-old hypertensive patient presented with insidious onset, gradually progressive palpitations from the past 40 years, insidious onset, gradually progressive breathing difficulty from the past 30 years, progress from NYHA class 2 to class 3 over 10 years, and from class 3 to class 4 from the past one week. And he has undergone a procedure, mitral valve repair. Wall repair he has undergone a wall repair 20 years back, and post wall repair he developed again symptoms, and he was told that surgery was not done properly, with no history of chest pain, no history of syncope, no history of hemoptysis, with significant past history of joint pains, joint swellings, for which he took penicillin prophylaxis for few years till he had undergone surgery.
Dr. Manjunath, your summary cannot be that long. So we are basically repeating 80% of what you had already presented. So summary need to be just about 4 lines or 5 lines, giving the most important historical data of your patient, and not repeating everything you have already said. And
So what is your diagnosis? From the history, can you come to any differential diagnosis?
Sir, definitely, sir. From the history, patient is having a cardiac problem and most probably left-sided cardiac problem. Most probably left-sided cardiac problem. It started with regular palpitations and breathing difficulty. I would like to think in terms of volume overload conditions.
Okay,
Volume overload conditions.
good.
With history of some wall repair, I would like to think in terms of regurgitation lesions.
Okay, good. So what valve? What level valve? Mitral, aortic?
Sir, with the history, Since mitral, I would like to consider mitral valve repair because of
Why? Why?
mitral valve repair.
Why mitral?
Sir,
Now, from the history, forget about mitral valve repair being done. You know that history, we know. But what is important from the history, basically, his complaint, basically 40 years, 30 years, breathlessness, 40 years palpitation. What is the possibility?
possibility will be, sir, mitral regurgitation.
Why? Why mitral? Why not aortic regurgitation?
Sir, that also can be considered out of both mitral valve regurgitation and mitral regurgitation and aortic regurgitation can be considered. In that, I would like to put mitral regurgitation as the first possibility.
Why? That is what I am asking.
Sir, patient has a history of joint pains, joint swellings.
So rheumatic
Strongly-
fever, the commonest valve involved is
Valve-
mitral valve. That is
mitral valve, sir.
so you
Yes,
go by commonness. One is more commonly involved is mitral valve in rheumatic fever.
Yes, sir.
One. Second point, why it is mitral? There is
There is
not aortic regurgitation.
sir, there is gradual progression of symptoms, which is slow onset. I mean, disease is gradually progressive.
Why AR symptom can be gradually progressing. Patient can have symptoms slowly progressive. Depends on the severity of the AR and severity of MR.
Dr. Manjunath, you said the patient had paroxysmal nocturnal dyspnea.
Paroxysmal nocturnal dyspnea goes more in favor of MR than AR. Yes.
Manjunath, which valve is more frequently repaired? Is it the mitral valve or the aortic valve which is more frequently repaired?
So more frequently repaired valve is mitral valve.
So by probability, you may start thinking that it could be a mitral valve disease. And of course, aortic valve disease cannot be excluded. But mitral valve is more frequently repaired than the aortic valve.
Correct. So
Can I?
then
The etiology of that? Do you
Sir.
have any clues in your history to suggest the etiology of your mitral regurgitation or mitral valve disease?
Sir, clues like there is a history of repair, one thing, and
No,
there is
repair
history
does
of-
not make it anything to do with etiology.
there is a history of rheumatic fever, na Manjunath?
yes, the history of rheumatic fever helps in suggesting the etiology of the disease. Maybe rheumatic might be the thing.
Now, what are the criteria that are satisfied in your patient to say definitely that it was rheumatic fever when he was 7-year-old?
Sir, criteria, since in India, this is a high risk population. So he had a involvement of joint pain. According to his history, both the knee joints and elbows were involved. So it was a picture of polyarthralgia.
Was there arthritis or it was only arthralgia?
It was inflammation as well as pain according to his history. So it was arthritis.
Was he disabled?
He was not. He consulted the doctor and he was not disabled. But immediately the symptoms improved after 1 week.
But
Within 1
it
week,
could be
symptoms improved.
spontaneous. No, it could be spontaneous remission of his rheumatic fever, which is actually common whether you treat the patient or you don't treat. Still, they do become normal after a few days to few weeks. The sequelae may remain, but the basic arthritis will resolve. Any other criteria which he satisfies? So according to you, now there is only one major criteria that is satisfied. Now at this point in time, we will be pinned down on a Duckett-Jones criteria, origin of those criteria, what were the original criteria, what were the subsequent modifications, and what is the latest modification, when was it. So they will tell you what are the current criteria of a Duckett-Jones revised and re-revised criteria. You need to be familiar with them, you need to be ready with them.
Yes, sir.
Are you familiar with that?
Yes, sir. The newer criteria says now they have considered with respect to low risk population and high risk population. Low risk population are the group are the countries where acute rheumatic fever among the children age group between 5 to 14 years, where incidence is less than 2 per 1 lakh population, and prevalence of rheumatic heart disease among the adults is less than 1 per 1,000 population.
Now, what is the data from ICMR in India? That is what you'll be pinned on. ICMR has 4 different studies over a period of time, the last one being 2002 or 3. So, what are the conclusions of that ICMR data in these 4 studies, how the rheumatic heart disease has evolved over a period of time? Because that is Indian data. And you also need to know the guidelines that are given by CSI, right? Criteria that are given by the CSI for the Indian context. So also you need to know the epidemiology of the rheumatic fever and the recent epidemics of rheumatic fever anywhere in the world. You know, you had one in Utah, United States. We have the most recent one is Denmark, and before that there was one in New Zealand, and few years before that there was one in Aborigines of Australia. So you need to know something about those recent epidemics. And also there is a study from Africa, right? Nigeria to be specific, the field study with echocardiography, and they have given data on echocardiographic epidemiological study of rheumatic heart disease, and it reveals something very important. And you also have studies done within India, apart from ICMR, you have data from Jayadeva Institute, Bangalore, and you have from All India Institute, okay? So like that, there was original data from Chandigarh, later on from Safdarjung Hospital, but they belong to 50s and early 60s. So you and Anita, I don't know whether you have read, Dr. Anita Saxena, now retired from All India Institute of Medical Sciences, has done an extensive collation of these studies and published in Indian Heart Journal. Dr. Anita Saxena and her colleagues. So when you are on rheumatic heart disease, you need to have reasonable understanding and reasonable information about these studies from all over the world, and more specifically our own country, India. At least ICMR, if not anything else. Have you heard of ICMR studies?
Yes, sir. Yes. ICMR, I have read about this.
Shall I? Audible or not?
Yes, sir.
You are audible, so that.
Shall I contribute?
Please do. Most welcome.
I think I will help the students, and later I will go back. I will take only 5 minutes. One, the issues which have been raised, how to answer them. The issue, the basic thing is rheumatic fever, you should know everything. That is the number one. It's a homework for you. Second was, what is the lesion and why it is say it is rheumatic. These are the 2 issues which were raised. Lesion, you said it is likely to be mitral valve. Now, how you can defend that is, one from the history, second is from the background data. The background data, I think, is most important for me because 20 years back, mitral valve repair, aortic valve repair, aortic valve repair is done only in children, very seldom at this age group. at the age of 30 years undergoing aortic valve repair is extremely uncommon. Because for aortic valve replacement is the usual thing. Maybe VSD with AR will be repaired. Aortic stenosis repair usually is done in the children. So that is statistics. Whereas mitral valve repair, I think whatever I have seen as an isolated valve repair is mitral valve repair. So provided you feel that the diagnosis by the surgeon was right, we accept that. There is one. Second is how, based on what symptom. You have dyspnea, which has progressed to paroxysmal nocturnal dyspnea, indicating a very high left atrial pressure. The left atrial pressure has gone beyond 25 millimeters of mercury, which occurs with the valve which is very close to that is mitral valve. Based on this, I will go for mitral valve disease, mitral valve repair. The second is what is etiology. There again, I start like that, accepting the surgeon's view. 20 years back, rheumatic mitral valve repair was extremely uncommon. Mitral valve repair was done for non-rheumatic mitral valve, but it is done. There is no doubt about that. The third issue raised by Rao sir was rheumatic fever. You have to straight away say that at the age of 70 years, that is 43 years back, we cannot recollect the details of that. There is my limitation in that. My limitation in that I cannot recollect the events which has occurred. I have a major problem. Real event which occurred, which triggered that issue. That was about 20 years back. I find it difficult. Can you recollect the details of the headache which he had about 1 year back? Very unlikely. So to say whether it is rheumatic fever which has satisfied the criteria or not, sir, I am not sure. But during school period, boy gets polyarthralgia, especially in the Indian context. I think one of the strong possibilities is rheumatic fever, especially because he developed a valvular heart disease. So that is the way I look at it. Because you have diagnosed valvular disease at the age of, and it is mitral valve disease. What is the etiology of mitral valve disease, which was diagnosed at the age of 13 years?
13.
What do you tell me the valvular lesion, the mitral valvular lesions, which is progressed and it was detected at the age of 30 years, at the age of 40 years or something like that, 13 years, at the age of 30. You say it is less likely to be congenital because congenital mitral valve disease isolated is extremely rare. Can you tell me the two common conditions of mitral valve disease which you are seeing at the age of 13 years?
Sir,
One is
rheumatic heart disease.
rheumatic, agreed. Second,
Sir,
mitral
mitral
collapse.
valve
Mitral collapse is
collapse.
much more common than rheumatic at the age of 13 years, especially nowadays or even otherwise. The incidence of mitral collapse is very common. So you have two possibilities. One is a rheumatic, second is a non-rheumatic. It could be either. With a history of joint pains preceding that, one of the possibilities which we strongly consider, was there any evidence of carditis? If it was rheumatic fever, there is carditis because the patient has developed valvular lesion at the age of 13 years. So if the patient has developed valvular lesion at the age of 13 years, and if it is rheumatic, it is carditis. So that is an indirect way you can answer. You may not be able to answer like the people we are doing. Now coming back, I would like to have a few criticism about your slides. Can you start from the first slide? If others permit, other faculties permit, I will go back because I make a certain comments because many times before putting it as Kolanjeri, the external examiner Rao sir doesn't know where is Kolanjeri. Our CSI president doesn't know where is Kolanjeri. So it is not important. You have to say he is hailing from the coastal area of Kerala or the high range like that. That will be more useful than putting as Kolanjeri. Second, that part, next slide. Next slide. I'll just give some modifications. It was too exhaustive, not really needed. Discontinued regular penicillin. Okay, fine. Then where was that palpitation? The previous slide. Symptom. History. When he started, our aim is, we have to say he was experiencing palpitation accession, which was regular and relieved by rest. There was no history of paroxysmal or arrhythmic palpitation. That is a thing which you can straight away say at postgraduate level. You need not stress the whole thing. Sir, it was exertion palpitation. There was no arrhythmic palpitation. To say that it was exertional palpitation based and it is due to volume load, it may not be very easy. Okay, but what we want to know is, was it arrhythmic palpitation or not? Okay, second, then don't put it as a valve. He was diagnosed a valvular heart disease. Don't use the layman language. And he was advised surgery. Okay, fine. Then next was climbing symptoms, class 2 symptom, all those things, could have normal sexual behavior. That was fine. Next slide. Next slide. Because he does not know why. He did not say it was a discontinued penicillin prophylaxis. He doesn't know. So the same thing about the history of joint pains, he cannot recollect. Then he had temporary improvement of symptoms because he was in class 3. You have to find out how he improved at that time. On stopping, now it gives an impression that on discontinuing penicillin, he had temporary improvement of symptoms. So he have to say he was put on aggressive medical management with which symptoms they improved. Then the next was his next slide. That is passing urine diet. That is you say he was put on diuretics. Don't use layman language at postgraduate level, at least at MBBS level. I still am not happy. So you can say he was put with the diuretics 5 days a week. The only drug which you know, any other drug you know which is taken 5 days a week. Any other drug? So say he was put on digoxin, diuretics, and probably management of heart failure or whatever it is, and other cardiac drugs. That would be a better way of presentation. Next slide. Next slide. Okay. He was diagnosed of hypertension and which was put on anti-hypertensive medication. Don't say which were the drugs. Okay, fine. Now, to summarize, as Rao sir said, this 53-year-old man with history of polyarthralgia, rather than putting joint pain, polyarthralgia, because you made it a very clear point that in the high-risk population, polyarthralgia is taken as a major criteria. Okay, so you could say that with the history of polyarthralgia at the age of 7 years, diagnosed of valvular heart disease at the age of 13 years, remaining in class 2 and worsening to class 3, undergoing valve repair at the age of 30 years. Then the question was, the previous slide, did he have symptomatic improvement only for 2 years? That you didn't highlight in your history of presenting complaints. Because what you said was valve repair 20 years back, and then you said dyspnea for 1 year. So what we are interested is what happened to this functional status from the date of surgery or from the surgical time. What happened? How much time he was in class 1? Did he go back to class 1? That is the number one thing. Because he was in class 3, he should go back to class 1 if it is a successful surgery. Was he in class 1 or he continued to be in class 2? Then the deterioration was after 2 years, post-operative. So there was a lacuna in your history of presenting complaints. You said valve repair at the age of 20 years, and then you started symptoms for the last 1 year. So you would have said he underwent valve repair at the age of 20 years or whatever it is, 20 years back, and he improved to class 1 or class 2. He remained in that status. That part was missing. That is, from the date of surgery to about 1 year back, there were no details, but you presented it later. That is the comments about the history. When you are asked to discuss, sir, history of polyarthralgia at 7 years, consider rheumatic fever as a possibility, but there are limitations. Second, symptom of progressive dyspnea. In a valvular heart disease, it is suggestive of pulmonary venous hypertension. Paroxysmal nocturnity indicates severe pulmonary venous hypertension, which occurs much more often with mitral valve disease, not mitral regurgitation. You say mitral valve disease, for which a repair was done. And the repair is most likely is mitral valve repair. So that is why you can provide. And now he has again features of pulmonary venous hypertension, which is severe. So his mitral valve disease has progressed. And you would like to assess whether it is mitral regurgitation progress, if it is rheumatic, whether it is mitral stenosis or regurgitation, we don't know. That's why I would like to discuss and make some comments about your presentation. Okay, sir.
Can I jet in?
Yes.
Yeah, having been an examiner for nearly 30 years for DM and DNB, I heard some questions from my co-examiners. So I would like to highlight them so that he is conscious of those questions likely to be shot at him. This basically, there will be more questions on penicillin.
Yeah.
Like, for example, why 3 weeks and why not 4 weeks? Because originally it was 4 weeks. And second thing is, suppose if the patient is anaphylactic to penicillin, what are your alternative options? Third question is, how long you give? When do you stop it? Because this patient, according to the story Dr. Manjunath gives, is after his valve repair, the sentence says he was advised to stop penicillin. That is very intriguing. I don't think any one of us have ever done that. Because if it was rheumatic valve, which was repaired, and then why the penicillin was stopped in the first place. And he says he was advised by the institution where he was operated. So it sounds quite unacceptable. So the question comes, when do you stop penicillin? How long will you give? That's one.
Sir, their
Uh,
penicillin profile. Okay, sorry.
So go on. If you want to answer, please go on.
Sir, their penicillin prophylaxis was stopped. So then we have to think in terms of like, so surgeon might have thought that the process might not be rheumatic and he might have stopped it. So we should keep other things also in mind because here surgeon has stopped penicillin prophylaxis.
But you don't have any alternative diagnosis from the surgeon. Did the surgeon say that it wasn't rheumatic, but it was mitral valve prolapse, for example? Or did he say that, did he take a biopsy of the left atrial appendage and look for the Ashoff nodules and see whether it was rheumatic or not? I might add here, we have done a study on this during the mitral valvotomies on surgical table. For one particular dissertation, we took a biopsy of the left atrial appendage and then sent it for histopathological examination. And the very interesting information is these Ashoff nodules have nothing to do with the activity of the rheumatic fever, or it is a lifelong rheumatic activity, because Ashoff nodules of some number are always present in the left atrium. So, but their presence will indicate that it is a rheumatic heart disease. So, was there a biopsy which was done, which was negative?
Yes.
So, the surgeon thought it was not rheumatic, or any other reason why he thought it was non rheumatic? We don't have that information.
I don't have the.
Yeah, we don't have that information. So, there will be a lot of questions here on penicillin, as I was telling you. So if you mention penicillin, then what are the current recommendations about how long you need to give penicillin and when do you stop? At least the most important question is that.
Sir, the penicillin injection has to be started if there is acute rheumatic fever, with history of acute rheumatic fever, and there is, the usual dosage is based on the in children less than 27 kgs and more than 27 kgs. We have to categorize them, and we have to give. If it is oral dose, we have to give 250 mg 2 to 3 times daily. If adult dose is 500 mg 2 to 3 times daily. If we are giving injections, it is less than 27 kgs, 6,000 international units, 6 lakhs international units. And if it is more than 27 kgs, we have to give 1.2 million international units.
But that was not the answer to my question. My question was, question one, when do you stop penicillin in a patient with rheumatic heart disease? That was question one. Question two is, if the patient is anaphylactic to penicillin, what are the alternatives? What are the studies? Then question number three is, if the patient is not compliant, right, or partially compliant, what is the breakthrough rheumatic fever incidence? This data is available in the epidemiology of the rheumatic fever from multiple studies from all over the world.
Need to stop it. Ideally, it should be given. If there is no carditis, it should be given up to the for 5 years or up to the age of 21, which is longer. If there is the signs of carditis, we have to give up to the age of 25 or 10 years, whichever is longer. And rheumatic heart disease repaired and established rheumatic heart disease, we have to give it up to the age of 40 years or can be lifelong.
The patient had a valve repair. Some patients may have valve replacement as well, some other patients. But why do they need penicillin after surgery?
there is chance that other walls may be involved, or there might be other walls might be involved.
Okay,
And
that is
also,
one important reason is that. Second important reason is what I told you a little while back. The Ashoff nodules were found in the left atrium and left atrial appendage for decades after the original rheumatic fever. So one of the major thought processes is that there is some smoldering rheumatic inflammation in the heart for many, many years, even after the acute event. So these are the two reasons why penicillin need to be continued lifelong if there is a cardiac involvement, or at least up to the age of 40 years if there was no rheumatic fever in the previous 5 years. These were the original recommendations, but they have been modified recently so that 40 years has been brought down to 25. Now, at this point, the other questions which will crop up are about the rheumatic fever vaccines. What is the current status of rheumatic fever vaccine? Do you have any idea?
sir, I have to be.
So you need to read up, rheumatic fever vaccines is a heartburn topic till recently, but once the incidence has come down, it has gone out of the radar, but may come back again. We don't know because there are new epidemics in many places now. Every 5 to 8 years, there is one epidemic somewhere in the world. Right? So you need to read up about vaccines. There are various types of vaccines, and there are reasons why they may not work as well as we want them to be. Right? And you also need to know the strains of streptococci and the various types of vaccines which are under development and what is the current status. Another thing which you need to know is what is the reason of an acute heart failure in an acute rheumatic fever. So I am giving you the questions which you will face in the examination because I have heard these questions year after year for last 3 decades. Why does somebody with acute rheumatic fever go into heart failure?
Sir, they can have acute mitral regurgitation, worsening, increasing the left atrial pressure, causing heart failure. Or
No,
acute
simple answer is the
worsening of
mechanical effect of the rheumatic fever. So acute mitral regurgitation or combined with or without aortic regurgitation, sometimes even with a tricuspid valve. So incidentally, this is another question which will crop up. How often the tricuspid valve is involved? Okay?
Sir, it is up to 15% tricuspid valve involvement is in rheumatic heart disease, TS. TR, more than 20 to 25%.
No, you have to divide that into two. One is clinical involvement, and two, autopsy involvement. Autopsy involvement is much more than the clinical involvement. Clinical involvement is to the tune of something like 10 to 15%, depending on various studies. But autopsy, 30 to 50%. Okay. Now, going back to the previous question, a lot of people think the heart failure in acute rheumatic fever is because of rheumatic myocarditis, which is proven to be incorrect. Because myocyte is never involved in rheumatic myocarditis. The interstitial tissue of the myocardium is what is involved in rheumatic fever, but not the myocyte. Okay, so the heart failure is basically related to the acute valve regurgitation, the mechanical load on the heart. That is the answer that is to be expected of you. And you need to know that myocyte is free of any involvement in rheumatic fever. The so-called myocarditis is the interstitial tissue. Because a lot of endocardial biopsies, endomyocardial biopsies have been done and have been proven that myocyte is not involved at all. All right?
Now that question come at that time will be about genetics of rheumatic fever also. Is there
Yes.
any familial tendency? Not only the socio-environmental factors, is there any genetic background? You have to read about that. Then as sir said, why
HLA phenotypes.
HLA phenotypes, all those things will be asked. They'll just give you the clues. Then why myocarditis is not there? Only studies by troponin, by biopsy, by MR, and by global strain, all those things. The systolic function is preserved in acute rheumatic. So you have to read about that. The next question will be why penicillin is given after surgery. One, as you have said, but we are not we are giving penicillin prophylaxis not to prevent the lesion. It is to prevent recurrence of rheumatic fever. It is to prevent recurrence of sore throat and rheumatic fever. Here is a patient who has severe carditis, will produce severe lesion. So he should be protected to the maximum. There is a basis for this duration. So he should not develop rheumatic fever. That is why we say that we should continue even after valve surgery, because valve surgery means it's a major issue. He cannot withstand another cardiac problem. There is a reason, and apart from the other things. I wanted to ask one question. Why did he develop symptoms after mitral valve surgery? What are the possibilities? Sir has been keeping quiet, Majaran sir, because he is his candidate. That may be the reason. That may be the reason why sir is keeping quiet. This is my final question before leaving to others. What the patient develops symptoms? What could be the possibilities? How will he approach? Following a mitral valve surgery or a valve surgery, the patient is developing symptoms. What are the possibilities and how will you try to differentiate it clinically? Yes.
Sir,
let us say mitral valve repair.
Mitral valve repair, post mitral valve repair, the repair might be unsuccessful.
So it could be
unsuccessful.
Unsuccessful in the sense what?
There is mitral regurgitation.
So the persistence of significant mitral regurgitation which may progress. Fine. Second,
there can be infective endocarditis.
No, related to the valve first, then related to the complications. Okay. Valve. So how will you do mitral valve repair in a non-rheumatic mitral valve and this thing? What are the procedures? This will be the question from my side. My questions will be, sir has asked about rheumatic fever. I will be asking, I have given you some discussion on the history, some limitations and some modifications. I may be interested in that mitral valve repair. How is it done? What are the problems? How mitral valve is repaired? What are the methods of repair? And what is the selection of the cases for each type of repair? So even though it is surgeon's area, we also have to know that. So what are the situations where mitral valve repair is done? What are the techniques employed in that? And what are the problems related to that? Then what will be the natural history of the symptoms after that? Okay, whether the patient had a good symptomatic relief. So we have to see whether it is related to the surgery, whether it is related to other valve lesion, whether it is related to myocardial disease or new onset disease, whether it is related to some complication like arrhythmias, infection, rheumatic fever, all those things. Now let me take only mitral valve repair. What are the techniques and what are the problems related to that? After that, I think Manjuran sir or Rao sir or CSI president may take up. Okay, go ahead. Mitral valve repair, method and consequences or natural history.
The mitral valve.
You are not sure, you say I'm not sure, so we can save time.
Sir, TEE translated mitral valve repair. TEER is done. That is one of the techniques.
The technique means repair. The surgeon, how does he repair? What are the things he do? If you are not sure, we'll discuss, or you can learn later. Okay, you should know how the valve is repaired, what the subvalvular apparatus is prepared, what is happening to the annulus, what are the problems. Might I say, subvalvular repair is very aggressive and very prominent nowadays, where the codae are preserved, caudal repair, neocodae, all those things you should know. Then the annulus, whether they are put in a ring. So based on that, they can have residual significant MR, or the valve may be a little more narrowed, or a combination of lesion can occur. So that you should know. then you should know whether it was extremely successful. So suppose the patient had total symptomatic improvement after that for a quite long time, it is a natural step, the basic disease process which has led. So we want to know that is the inadequate or problems related to the technique or problems related to the disease, new disease, like that you have to analyze. So you should read mitral valve repair, all the methods of mitral valve repair. Is it done for rheumatic mitral valve disease? What is the data available on that? What is the success rate up there? We will ask you questions on mitral valve repair, mitral valvotomy. We get a chance to talk about PTMC, balloon valvotomy, mitral valve repair in rheumatic heart disease and otherwise. What is the natural history? All those things, I think, as Rao sir said, it's really give you only the questions. You read it and be prepared for your regular examination. Okay. Panjaran sir has been keeping quiet. Sir, unmute, sir. Sir, unmute. Sir, you are muted.
No, I thought he is my candidate. I think he should learn from both of you. So I actually told him that this is a golden opportunity to get an exposure to other examiners and their thought process. So I thought you should. I need not ask questions because I can still continue to ask him tomorrow also.
Okay. You can assess him and give you a rating also.
Yes, yes.
So how he has performed. Then
I
Raj,
just have one question to the presenter. Hello. Can you hear me?
Yes, sir, I can hear you.
Okay, if you can hear, my question is, have you ever been in cardiac surgical operation theater watching any cardiac procedure, specifically mitral valve procedure or any other procedure? Because I find these days, none of my students, we have 4 students every year, which means 12 at any given time. I have found that none of them ever enter the operation theater. None of them know anything about what procedure is being done, what immediate post-op problems may come. So when they are called in to assess post-operatively, they are completely lost in a black tunnel. They have no idea. So my question to you is, how many cardiac surgeries have you attended in person?
not doing, observing.
No, you can say, no, you haven't attended. Be honest. You will learn when you are honest.
The usual thing is, sir, during the posting, nowadays, the things have changed a lot from clinical to more of what they want after their post-graduation. So they concentrate on intervention. They are fairly good in intervention at the end of 3 years. Regarding surgery, they take it as a leisure time to skip the posting. Then I have seen that many centers or in sizable number of centers, there is inadequate exposure to echocardiogram. And I don't know whether they are witnessing treadmill. Treadmill is done by technicians. And the reporting by the technician, we have seen, all of us agree that that report we can't trust too much. We have to read independently. And these are the limitations of the present day training. One is exposure to echocardiogram, exposure to treadmill, and electrophysiology. They can say that the facilities are limited, but those who are interested in electrophysiology in their future, this thing, they go and get trained in electrophysiology. Surgery, as sir suggested, only very few or very seldom that they attend the surgical procedures. Okay. Transesophageal, they are getting experience in transesophageal echocardiogram. They are very much interested in global strain because it is relatively simple. But the meticulous evaluation of the echocardiogram, hands-on training for echocardiogram is not available or not given in some centers. I will not say all the centers are majority in some centers. That's a problem in the present day training also, sir. The present day training, the discussion is predominantly on interventions, electrophysiology, congenital heart disease. The exposure to congenital heart disease is also relatively less because now you get some congenital heart disease the other people, that is a non-cardiologist, including clinical cardiologists, refer to the pediatric cardiologist. So this is some of the limitations of the present day training for which we are also responsible. But that's not an excuse for Dr. Manjunath for not answering the questions. You should read. Okay, sir.
So that opens another big area, which I thought I will ask later on, but now that you brought it up, I would have liked to ask Dr. Manjunath, who is presenting the case, so about the mitral valve repair. How do you decide whether the mitral valve repair is feasible or not feasible? What type of technique you'll use? Annuloplasty ring, or you will use resection of the leaflet, or closure of the fenestration, or lengthening or shortening of the cardae, or neocardae, so on and so forth. Now, what echocardiographic quantitative data you will obtain during the echo study of this particular patient if you are contemplating on doing a valve repair? This is a question which I wanted to ask him when he was about to show the echo later on. But
Okay,
you
fine.
opened the door now, so I thought I'll put that now.
Sir, things like we have to look into the cooptation area. So how much is the cooptation length? And second thing is caudal length. Caudal length we have to assess. And third is involvement of the mitral leaflets, anterior mitral leaflets and posterior mitral leaflets along with the subvalvular apparatus, and and assessment of calcium. Calcium also will help. And
No, the most important data is the annulus diameter.
annulus diameter.
That's one. And then length of the leaflets, surface area of the leaflets. And then the cardae, as you were mentioning. Okay. And then suppose if it is a functional mitral regurgitation, there are more things to be looked at about the papillary muscles. Are they normal or abnormal? Right? Single pap muscle or two normal pap muscles or fibrotic pap muscles. All right. And then 3D echo. 3D echo is extremely important to know about the mitral valve structure and anatomy. So 2D echo is not good enough. And also look for the, you will have tenting, particularly in secondary mitral regurgitation. So you have to check on the quantitative parameters of tenting area, tenting length, right? So there are more parameters, which I will not go into that, but these are the foremost parameters which you need to have before you can decide whether that particular valve is suitable for repair or not. And when do you get the best repair? Under what anatomical circumstances of mitral valve you get the best repair?
You're not sure, say I'm not sure, sir. That will be better. These are not familiar questions to you.
Not sure.
Not
Okay.
sure?
You should
So the
read.
best result you get is for fenestration of the leaflet, either congenital or acquired fenestration of the leaflet. The surgery is easy because you just have to put a pericardial small patch over that, and result is excellent. If it is a mitral valve prolapse, P2, the posterior two scallop prolapse gets the best result. But if the patient has anterior leaflet prolapse or bilateral, bileaflet prolapse, the results generally are not very satisfactory. So isolated posterior leaflet prolapse, particularly with P2, you get the best result. And the most important variable, of course, is the patient, what the type of anatomy of the valve. Second most important variable, no offense meant, but everything should be known to you because you are in your early stage of your career, is the surgeon. Not every surgeon can do mitral valve repair. Every surgeon can do bypass surgery, but very few surgeons can do mitral valve repair. These days, bypass surgery has become as simple as vasectomy, right?
Surgeon should not hear that, sir.
They would
Right.
act. So, you cannot send your patient for mitral valve repair to every center you know or to every surgeon you may know. You have to choose the high volume center, high volume surgeon who is regularly doing mitral valve repairs. That is the punchline there. Remember that. So I am off.
Okay, sir. So before going to the physical findings, I'll just contribute the way you have to answer that question. Mitral valve repair, mitral valve surgery or mitral valve repair. First, you have to identify whether it's a primary or a secondary MR. Okay, not in this case when that question comes. Then primary MR, as said, we have to assess the annulus, the leaflet, subvalvular apparatus. That also you have made it very clear. Then in the this thing, as sir said, fenestration, it is a cure. Then leaflet prolapse, single leaflet, P2, that's better. But even by leaflet prolapse, you have the criteria. You have to go for that. I think it is the European Society where they have given clear description about primary MR, indication for surgery in secondary MR. That also is described. What is the criteria? Another important thing, which I think I'm sure sir will agree, is the annular diameter. If that regurgitation is significantly contributed by the annular dilatation, then the results will be very good. The structurally other contribution is relatively less. So these things also you should keep in mind. Shall we go to the physical findings, sir?
Yeah.
It's almost 1 hour.
I will add one sentence there. A lot of times the concentration is on the primary valve disease, in this case, particularly mitral valve disease. And unfortunately, many of the times the tricuspid valve is ignored. So I have quite a few patients where a successful mitral valve surgery has been done by a competent surgeon and good result as far as mitral valve is concerned. But in a year or two, they come back with pure right-sided heart failure because of unrepaired, unoperated tricuspid valve. So, just because you made a diagnosis of mitral valve disease does not mean you can ignore the other valves. So when you are doing an echocardiography,
So they are already 1 hour has elapsed. I think we have got time only up to 12:30.
okay. No, I am ending it. This is the only sentence. So when you are evaluating a valvular heart disease, look at all the 4 valves, right?
Yes, sir.
So that is the byline.
Yes, sir.
Shall we go to the findings, sir?
Yeah.
Okay, go ahead. So another 30 minutes, we have to discuss the findings, diagnosis, investigations, and management. Okay, fine.
So you can already. BMI is 20.
There's some problem with your audio.
You're not audible, Dr. Manzunam.
Sir, is it audible, sir?
Okay, fine. You can go to the next slide because there is nothing contributory in this slide. Next slide, please. Well, we can save time. Okay. Don't put it as this extra precordial. All those things is not needed. Subtitles are needed. You come to the point. JVP, pulse is first, blood pressure is next. Now, I'll tell you, this may be okay, but I still follow the MBBS format of presentation in a modified manner. First thing you examine is the pulse, blood pressure, respiration, systemic oxygen saturation, temperature, then go to the JVP precordium like that. And now this, I won't take it as an extra precordial examination. I don't want subtitles, but it should be pulse, blood pressure, respiration, temperature, SO2, and then JVP precordial examination like that. I think Manjaran sir will agree with me. Rao sir also will agree. So, okay, go ahead, pulse.
Sir, pulse is 75 per minute. Sir, audible? Audible, sir?
Yeah.
Pulse is 75 per minute, regular, high volume, collapsing, with no thickened vessel wall. All the peripheral pulses are felt, no radio-radial, no radio-femoral delay, and pictures of sounds.
Okay,
And
medical signs of AR. Go ahead. Because at postgraduate level, we don't ask about the signs. Because all these signs are determined by which factor? All these signs, what is the hemodynamic contribution?
by the peripheral runoff.
And that is hemodynamically, it is the white pulse pressure with a low diastolic pressure. So for that, you have something 17 signs. I'm not bothered about that because we have so many other things to learn. Okay, blood pressure is 170/40 with right lower limb.
Is 175/40 with 130 pulse pressure, and the right lower limb blood systolic BP is 120 millimeters of mercury. And
Okay,
coming to the JVP is not elevated, sir. With the sternal angle, normal wave patterns are seen.
okay. Next slide. We'll make it quick. Okay.
Coming to the inspection and palpation, together
Yeah.
apex BT is in the sixth left intercostal space, 1 centimeter outside the anterior axillary line, and it is forceful. No thrill or sounds palpable at the apex. No parasternal lift. No sounds or thrill felt at the base of the heart. Pulsations are felt in the suprasternal notch, and abdominal aortic pulsations are felt in the epigastrium. Percussion, left border corresponds to the apex, right and right side intercostal space second and third close to the sternum. There is a dullness up to 3 centimeters from the sternal border.
Forget
on the right
about
side.
that. This will accept only if you have seen the X-ray. It is extremely difficult for me to percuss the second and third right intercostal space. So we don't bother very much about that because we know the skill, your skill in percussion, because you will prove that your skill in percussion is much better than in other areas. Okay. It's an extremely difficult thing. Okay. Have you felt pulsations there? That's a problem because I am just to save time. Otherwise, I have to come back. Is it easy to palpate or percuss? Here is a patient who has a hyperdynamic circulation, suprasternal pulsation. I expect pulsation in the second and third space. You have said there are no pulsation in the base of the heart. Okay, so that will be easier. I'm sure that if you can percuss this up to 3 centimeters from the sternal border, I will be able to palpate it. Okay, because I am not at all good in percussion. Okay, fine. Because that's the biggest thing, because you are likely to land up in problem because seldom we do that. And it is not an easy finding percussion. And we don't concentrate too much on percussion also. And the only thing which I concentrate in percussion is where is the heart? If I cannot palpate the apex beat or where is the heart? Is it levocardia, dextrocardia? And important is situs. These are two areas where for me the percussion is important because all the other things I will get it by palpation. Third is whenever you find a chronic systemic venous congestion with no other major findings, I would like to know what is the size of the right atrium. To pick up the right atrium, in a case, this I am talking about the practical aspect. To percuss the size of the right atrium in a particular situation where there is gross systemic venous congestion with minimal findings to differentiate that is a huge right atrium of RVMF or a dilated heart of Epstein's anomaly or a normal heart of constrictive pericarditis. This is the situation. So my percussion is to see where is the heart. If it is not possible for me to pick up where is the heart by palpation and inspection, situs solitus or inversus, extremely important in congenital heart disease, and a chronic systemic venous congestion where the other findings do not contribute to see what is the right atrium. A huge heart of right ventricular EMF, a large heart of Epstein's anomaly, or a normal heart size of constrictive pericarditis. So percussion I may not concentrate, but here I will ask questions on these things. Okay, fine. Similarly, second sound, if you are asked to percuss, you should concentrate on the second space because we are interested in the pulmonary artery dilatation, which again is difficult. Unless you palpate the pulse in the second space, you will not be able to percuss it out. Previously, we used to do percussion as an important thing in pericardial effusion. Pericardial effusion, we were asked to do percussion, both percussion at the base of the heart and the body of the heart in supine sitting. And the other percussion is, what is that, sir, called in supine position? Okay, forget about that. Go ahead.
The right border dullness of the heart does not extend beyond the sternal border.
Okay, go ahead. Auscultation.
Coming to the auscultation, S1 is feeble and S2 is best audible in the pulmonary area.
Don't
Normal
put
intensity.
best audible at mitral area. Don't. I'll just criticize because we'll save time. Don't say best audible at the mitral area. I will ask you, what are the situations where it is better heard in other areas? Tell me quick. What is the situation where S1 is better heard in other areas?
It is there.
When it is
Better
contributed
heard
by
in
the
mitral area.
tricuspid valve. No, when it is
Right.
contributed by the tricuspid valve, as in Epstein's, it will be better. It will be heard all over. Then ASD, it may be better heard over the tricuspid area, but it will be equally well heard in the mitral area in ASD. But in Epstein's, probably it is better heard. Don't use that term. You will face more questions. Second sound?
Second sound, it's a normal, sir, and there is a normal split. And no S3, no S4.
No, but we are interested in the intensity of the P2. We would like to know
Normal.
what is the LV. Inspection, palpation, and auscultation. Is it LV? Is it RV or biventricular? Pressure load or volume overload? Is there pulmonary hypertension? And what is the iota? Then certain other things like pressures, all those things. But basically, we should know what is the cardiac size. Is it LV enlargement? Is it RV enlargement? Is it pressure load? Is it volume overload? What is the PA pressure? This is a very important thing. Then systemic venous pressure and rhythm, you have already mentioned. Cardiac output or the pulse pressure, you have already mentioned. So P2, you should say. You didn't
So
mention
P2,
about
it is normal, sir.
It's normal, fine. No S3 or S4.
No S3, no S4. There is a constant ejection click heard in the second and third right intercostal space.
There again, it will be asked because if you think it is an aortic, where is it best heard usually or equally well heard?
It is best heard in the second left intercostal space.
No, it is usually, I modified it as equally well heard. In the apex, that many times the aortic events are better heard, the clicks are better heard. Aortic click is equally well heard over the apex bit. Okay, these are some modifications you have to make. Okay, murmurs.
Murmurs. There is a pansystolic, blowing, high-pitched murmur, best audible at the apex. Best audible at the apex connected to the axilla, better audible in left lateral position with no change in breathing of grade 3/6.
There you will
And,
be asked about the dynamic auscultation. Okay, you should be ready with. So as Rao sir said, we'll give you the questions because giving the answers will take a long time. So you should be ready with dynamic auscultation in cardiac murmurs, especially when you have a mitral regurgitation murmur. Should describe that. Breathing, fine. One or two, not all the things. Okay, fine.
Sir, dynamic auscultation for MR, we should
Forget about that. Go ahead.
Oh.
2 second
early,
murmur.
there is a early systolic, blowing, high-pitched murmur, audible in the fourth and fifth left intercostal space, close to the sternum, increases on inspiration of grade 2/6.
Okay. But there are no B
And,
waves. There are no B waves in the JVP. Okay, fine.
Yes. And there is a mid-systolic, rough, harsh, medium to high-pitched, early peaking ejection systolic murmur heard in the second right intercostal space, close to the sternum, better audible in sitting up and leaning forward
I
position.
always told you better sitting up and leaning forward is only for aortic regurgitation, not for aortic ejection systolic murmur. Okay. In aortic regurgitation, the murmur is so soft that you may not be able to hear the direction of jet. Not for any other murmurs, to my knowledge. Okay. Others will modify it later. After I complete the criticism on the findings, Rao sir will discuss. Close to sternum, better audible in sitting up, leaning forward. With breath held in expiration, never say that because you are doing dynamic auscultation. In AR, because it is a faint murmur, the respiratory noise may interfere with the auscultation. We ask you to auscultate during breath in held in expiration. It's always dynamic auscultation. Respiratory variation is dynamic. During quiet, fairly good respiration, not held in respiration, only for that thing because of the other factors, not the dynamic component. It is a faint murmur. The respiratory noise may interfere. So in a quiet room, breath held in expiration, so can hear the AR murmur in a better fashion. Okay. The fourth murmur is early diastolic, blowing high pitch murmur.
High-pitched murmur,
Okay.
heard in the second
Right.
right second intercostal space, heard along the left and right sternal borders, right side more than left side, extending up to the late diastole, better audible with the patient
Okay.
sitting up and leaning forward position with a height of expiration.
A
And,
low pitch
there-
mid-diastolic rhumban murmur at the apex.
There's a
Below
low pitch
pre-systolic
mid
accent.
rumbling murmur audible at the apex with no pre-systolic accentuation.
And you have 5 murmurs.
Yes, sir.
We have combination of MR, AR, TR, and 2 other murmurs.
Yes.
So the most important thing in question will be on second sound. What will happen to a second sound in these lesions? That will be my question. You have to learn that or learn from sir. My question will be on second sound, how these lesions will inter-assess the second sound? MR,
Sir,
AR, TR. No, you need not answer that because we don't have much time. These are the questions. Rao sir said, we'll give you the question, learn the answers. Next, other systems normal?
other system examination normal, sir.
Okay,
Liver is
fine.
not enough.
Rao sir. Rao sir.
Is
Now
it
you
my
can
turn?
take. Yeah, your turn, sir.
Yeah. As you have pointed out, if your early diastolic murmur is well audible in supine position, actually there is no need to make them sit up and examine them in respiratory cycle. If there is a doubtful early diastolic murmur, right, then you may do that. In fact, the best way to bring out a subclinical early diastolic murmur or a doubtful grade 1 early diastolic murmur is knee chest position. Knee chest position is used for early diastolic murmurs which are doubtful, and 2, pericardial rub. So having said that, now my friend Manjunath says that he is able to hear the murmur in supine position, early diastolic murmur. So there is no reason why you need to make the patient sit up and waste his time and your time. That's one. And second thing is, you have said there is a early systolic blowing high-pitched murmur audible at fourth intercostal space increases on inspiration.
Yes.
So here you are hinting at something. So we'll come back to that later. Now the pansystolic murmur is real pansystolic murmur, or is it something like mid-late pansystolic murmur, or where is it radiating? Because you said it is conducted to axilla. So what is the importance of that so-called conduction to axilla? Because in some patients, it may conduct to left parasternal border, and some rare patients, it may conduct to right parasternal border. Even more rarely, second right intercostal space, even more rarely into the carotids. There have been rare occasions where we mistake it for aortic stenotic murmur because we are able to hear it in the carotid, right? Now the question is, what is the significance of that best audible at the apex, conducted to the axilla? What does it tell you in terms of mitral regurgitation?
It tells about the involvement of the mitral leaflets.
No. Means what? What do you mean by that?
Sir, if there is a AML involvement, that will be directed towards posterior. So axilla.
Regurgitation can be of multiple types. It can be posterior eccentric mitral regurgitation, or anterior eccentric mitral regurgitation, or central orifice mitral regurgitation, or transvalvular mitral regurgitation, or periannular mitral regurgitation, or multiple mitral regurgitation jets. All of them behave somewhat differently. So clinically, you will get a clue. For example, if the patient has what you say he has, it means that it is a posterior eccentric mitral regurgitation, which means dominant involvement is the anterior mitral leaflet. So if it is going towards the left parasternal or right parasternal, it is the posterior leaflet. All right. Now, if there is a central mitral regurgitation, you may not hear the murmur at all. Sometimes. So absence of murmur does not rule out mitral regurgitation. So we have patients where there is severe mitral regurgitation. In fact, even in heart failure, but you don't hear the murmur at all. But when you put the color Doppler on, you are stunned to see a very severe mitral regurgitation. So murmurless mitral regurgitation, murmurless mitral stenosis, aortic regurgitation, tricuspid regurgitations are not uncommon. So no murmur does not rule out any valvular disease. That is one lesson which you need to learn. Next slide. Next.
Next, other systems normal, sir.
Okay. Now no, stay there.
Done.
Now here you are saying there is a mid-systolic murmur, right second intercostal space, and then there is a very important observation which you are showing here. It is louder on the right than the left parasternal area. That's what you have written.
Yes,
Is that right?
yes, sir. It is heard both in the left and right intercostal space, but it is louder on the right side than left.
Right more than left. So
Yes,
what's
sir.
the clinical significance of that?
Sir, aortic root is also involved.
Pardon? What are you saying?
He is saying that the aortic root is involved.
Aortic root.
Sir, your question is on early
Yeah.
diastolic murmur. Am I right, sir?
Yeah, about early diastolic murmur. So you are right that if the murmur is really loud on the right than the left, then if it is a left-sided heart, we are not talking about right-sided hearts. If it is a left-sided heart, so which means that there is something wrong with the aortic root. Either there is an ectasia of the aortic root, or there is an aneurysm of the aortic root, or there is a eccentric regurgitation, eccentric murmurs, going in different directions.
Okay.
Eccentric murmurs also heard in peculiar
Right.
locations, not in the classical locations.
Yes.
Okay, then you also heard a diastolic rumbling murmur audible at the apex. So here the obvious questions will be, do you think that this patient has a mitral stenosis? That is one. Or do you think this is an Austin Flint murmur? Or do you think this is a flow murmur of the mitral regurgitation?
Sir, this is looking at all the findings. This is looking like a Austin Flint murmur, sir.
No,
Yeah,
it won't announce I am Austin Flint murmur. But on what basis you are saying what you are saying?
By combining all the findings, it is looking like a Austin Flint murmur.
Manjunath, you listen to the question. It will be easy for you to answer. First question was, is it mitral stenosis? Is it Austin Flint? Is it the flow rumble? Which is the simplest thing to answer in this? Three things, sir, as raised.
Sir,
You can solve
yes, sir.
it so that this is less likely to be.
Yes, sir.
That is the first question, sir, asked. Is it
Sir,
mitral
I am not
stenosis?
getting.
Is
Yes.
it mitral stenosis? Is it
Sir.
Austin Flint? Is it mitral flow rumble of MR? That's the question, sir, asked. So you take all the three things so that.
Sir, it is.
Yes, go ahead.
Sir, it is looking like Austin Flint murmur. It is not the organic mitral stenosis, as there are no components like opening snap. There is no presystolic accentuation, so unlikely to be a organic mitral stenosis. So
the simplest thing
this
is S1. S1 you should answer first. Okay, go ahead.
S1 is not loud.
Sir, you go ahead,
Yes.
sir. I try to help him. Okay, sir.
Okay. Then the 2 and 3. Is it, how do you know it is Austin Flint? It won't announce that I am Austin Flint. Like you announced that you are Dr. Manjunath, that murmur does not announce that I am Austin Flint.
Sir,
it is for you to make out.
Yes, sir.
Because these are the
Sir,
automatic
Austin
questions
Flint.
on that particular number 5 murmur. These are the automatic questions. So how do you distinguish Austin Flint murmur from the other murmurs? 2, what is the mechanism of this Austin Flint murmur? These
Sir,
are the questions that will be asked.
So differentiating Austin Flint murmur from mitral stenosis murmur, the S1 will be loud in mitral stenosis murmur. S1 may not be loud in Austin Flint murmur, and Austin Flint murmur will not have presystolic accentuation. Opening snap will be absent in Austin Flint murmur, and also mechanisms of production of Austin Flint murmur are there are some
Stay there. See, you said first heart sound will be loud. you are talking about pure mitral stenosis. But remember, the patient you have in your hand is a multivalvular disease.
Yes, sir.
So each valvular lesion will influence the other valvular lesion.
Yes, sir.
Like for example, mitral regurgitation, first heart sound will be muffled or soft or whatever, except in certain situations.
Yes,
As a rule, it is soft,
Yes, sir.
except when it is due to certain one or two conditions, which will not go into those details.
Yes, sir.
So it is not going to help you. Now, opening snap. Opening snap is not always present in mitral stenosis. Suppose if the valve is fibrosed,
Yes, sir.
valve is calcified, or if there is a very bad fibrotic fusion of the subvalvular mitral apparatus, then you may not have a opening snap.
Opening snap.
So absence of opening snap does not rule out mitral stenosis. Presence will help you. Absence does not help you.
Yes, sir. Sir, other things like thrill, diastolic thrill will be the present in the
Diastolic thrill is not always present.
sir, dynamic maneuvers.
So in the presence of a three-valve disease, how much your dynamic auscultation will help you. You are talking about an isolated valve disease, but here what you have is a multi-valve disease, three-valve disease.
Yes, sir.
So the answer is it is very difficult. The answer is very difficult. So it is more, if it is a rheumatic etiology, that mid-diastolic murmur is more likely to be mitral stenotic murmur, maybe a mild mitral stenosis. If it is a very torrential, severe mitral regurgitation, it is possible that this murmur may be because of
Flow murmur.
flow murmur.
Increased flow across the
Three, this patient also underwent valvular repair. We don't know what they have done, what valve repair they have done, we have no idea. But suppose if there is a ring which they have put in, that ring itself can produce a mid-diastolic murmur.
Yes, sir.
So my take on this thing is, it could be any of them.
It could be.
Because this is not pure mitral valve disease, this is a multi-valve disease. So it is difficult to decide on that. But dynamic auscultation, if you can lower the aortic regurgitation, right? How do you increase or decrease aortic regurgitation? You increase aortic regurgitation by isometric exercise.
Yes, sir.
Isometric exercise.
Isometric
Or giving a vasopressor.
vasopressors.
Then, if the AR is increasing, Austin Flint murmur should increase.
Yes, sir.
If the AR is increasing, if it is mitral stenosis, it should decrease.
Decrease.
Because LA-LV gradient will be narrowed down
Narrowed.
with increasing AR. Okay.
Yes, sir.
Or if you decrease the AR by giving a vasodilator, all right, then if that is so, then your Austin Flint murmur may disappear or may become shorter.
Yes, sir. AR decreases and Austin Flint decreases.
Yeah. Dynamic auscultation can help when you manipulate the aortic regurgitation, either increase or decrease. It can give a clue to that. But overall, when you find a patient with rheumatic history, which is convincing, and multi-three-valve disease, is more likely to be probably some severity of mitral stenosis. That is only a guesswork.
But are you thinking in terms of the etiology? Because sir is very much concerned about the time factor, sir, now.
Already,
Sir, with respect to few clinical findings like AR murmur with aortic root dilatation.
What is your diagnosis? Now tell the diagnosis. Complete perfect and diagnosis.
Physical diagnosis, which should include everything. Etiological and
I think
anatomical,
basically,
physiological, complication, functional status. All these things should be included in your diagnosis.
basically, when you put the diagnosis, the straightforward, non-controversial thing should be written first. Then you can say the things which you are not sure but possible as possible. Here the etiology, now you are going to debate with us, with the previous doctors also. What are the things which are severe? That's because we are running short of time. That's why you are
Sir,
severe
aortic
about.
regurgitation is severe.
No, you put it like this. It's a valvular heart disease. You can say definitely.
Yes, sir.
Aortic regurgitation severe.
Yes, sir.
Mitral regurgitation, you are not sure what is the severity. I will ask the question later, because in a patient with severe mitral regurgitation, how to assess the severity of MR? It's a very difficult thing.
Yes, sir.
Tricuspid regurgitation, you say mild. That also is not an easy thing. Okay. Status post aortic valve repair, it's a very unusual thing in these types of situations where you are entertaining. So status post valve surgery or valve repair, rather than saying aortic, status post valve repair, congestive heart failure treated okay. Sinus rhythm should go ahead of that. NYHA 3 or 4 should, so again, before no signs of infected endocarditis. Systemic hypertension control, you can't say. Why do you say systemic hypertension? What is the proof for that? So whenever the systolic pressure is more than 140, that doctor might have diagnosed hypertension. Here again, the systolic pressure is high. So you can't put it as systolic hypertension, systemic hypertension now, because we don't know whether at present the pressure which he has is related to the aortic regurgitation or due to primary systemic hypertension. So these are the things which you have to modify. So etiology I would like to discuss. Okay. Etiology you would like to discuss. Okay.
Sir,
Now, why do you say iotopathy alone? Because we have mitral regurgitation. You think mitral regurgitation is valvular or secondary to AR? The
Sir,
issue comes. Now, I am telling you the limitation because Sir Edikon Nyangala Noki, Manjaran sir was looking at us that we are exceeding time. So these are the points which you have to keep in mind. We are not sure about iotopathy, aortic root dilatation. Okay, that we are not sure. Now, let us put like this. Etiology could be a patient has mitral regurgitation, the patient has aortic regurgitation, the patient has, you have picked up dilatation of the aortic root. What could be the etiology and what you would look for in the general examination? This is my final question because of time factor. What is likely and what will you look for in the general examination?
sir, I would like to look for the morphonoid features.
Yeah, that's it. So you put the whole thing and then say, sir, whether the whole thing could be explained by, it's not only root dilatation, it's a connective tissue disorder.
Connective tissue.
Disorder like Marfan. If you had discussed like that, I would have given you bonus mark. Because of that running short of time, Rao sir.
Yeah, just a couple of things. It is hypertension, but you could use the word expression isolated systolic hypertension.
Okay, sir.
The etiology of isolated systolic hypertension can be AR, or there are so many other things. That is one correction I would like to make. And then Marfan's, in your general examination, you made no mention about any of the parameters which you look for in Marfan's. You use the word morphonoid, right? Now you are getting your foot into mud. Then they will ask you what is the difference between Marfan's versus morphonoid. All right? And two, you should, in all, it is a statement now, in all patients with valvular regurgitation, you need to look for features of Marfan's. So you should have made it part of your general examination. Right? Height span, arachnodactyly, iridodonesis, etc. Particularly when you are talking of aortopathy, but you haven't mentioned the skeletal features or other features of Marfan's. You should have in your general examination. I'm done. I'm done, Dr. Suday Kumar.
Yes, sir. Iotopathy you should not put because you have to explain the mitral valve also. Second thing, you had mitral regurgitation and aortic regurgitation, and if single repair was done, it is more likely to be mitral repair, because if there is a huge aorta with iotopathy producing AR, they have to do something more than repair. So these are some of the things which you could have avoided. Start with valvular heart disease, aortic regurgitation severe. Sir, associated mitral regurgitation severity I would like to discuss, because assessment of severity of MR in presence of severe AR is difficult, because you can have ventricular dilatation, this one can be soft, you can have the mid-diastolic murmur. Severity of tricuspid regurgitation is not easy. It need not be there, the prominent VV. Sometimes Manjuran sir might have picked up VV. It might have come down with treatment. So those are things which could have modified. And finally, you say, sir, say aortic root dilatation, aortic regurgitation, mitral regurgitation. It could be part of a connective tissue disorder that, like Marfan syndrome, or it could be connective tissue disorders of other type. But whenever you say aortopathy straight away, at least what comes to my mind straight is something like a Takaisus arthritis. I'm not right, but that is the thing which may come to my mind. So don't put iotopathy as your first diagnosis. Solid things first. With aortic regurgitation, with aortic root dilatation, you can put. Or you can say that in view of aortic root dilatation, significant, there is an evidence of aortic root involvement. So the whole thing could be, you can discuss that. You need not put it straight away, this thing. Shall we go to the X-ray and ECG quickly?
Yeah,
Manjuran,
just
sir?
one comment, Dr. Sudai Kumar.
Yes, sir.
Yes,
Just
sir.
one comment. Now, he should have started saying that valvular heart disease.
Yeah.
Yes, sir.
Then severe aortic regurgitation.
Yeah.
Then severe mitral regurgitation,
Okay.
mild tricuspid regurgitation. Rather than the way he started aortopathy,
That's
so
it.
that gives a wrong impression of your analysis. Students' analysis.
Yeah.
Second point,
Next I can write like query involving the aortic root or etiology with respect to etiology. Possible.
that will come at the end after your congestive heart failure.
Okay, sir.
Etiology, sir,
Because-
I would like to discuss aortic root dilatation, aortic regurgitation, mitral regurgitation. One of the possibilities strongly I consider is a connective tissue disorder like Marfan syndrome. However, there are no dysmorphic features or other skeletal abnormalities of Marfan syndrome. That should be enough. Our limitations also we have to tell. We need not be 100% right in the final diagnosis.
The second comment I would like to make is, you need to know in a multivalve disease, what is the hemodynamic impression of one valve lesion on the other.
Yes, sir.
So what is the effect of mitral regurgitation on mitral stenosis? What is the effect of mitral stenosis on mitral regurgitation? What is the effect of mitral stenosis, mitral regurgitation on aortic regurgitation and aortic stenosis? And these together on tricuspid valve. So multivalvular disease is very, very difficult to analyze purely based on physical examination. That is the reason why all the criteria that are given to assess the severity of the valve lesion are for isolated valve lesion, not for the multivalve lesion. Do you understand?
Yes,
that
sir.
last
Yes, sir.
sentence is very important. So all the criteria are for the isolated valve lesion,
Yes, sir.
not for a multivalve lesion. Two, each valve lesion may have its hemodynamic impact on the other valve lesion. So
Yes,
your
sir.
clinical findings may be variable. Your even X-ray or ECG may be variable. So don't bet on some of these things in a patient who has 3 valve lesion. I'm
Okay,
done.
sir.
Manjuran, sir, do we
No.
have time?
No, see, actually, it should have been over by 12:30, but I think you should continue. I think he will have a good experience of.
Sir, you should raise your hands when we have to curtail. That will be easy. You can just raise your hands.
But I am not the controller because the chairperson should do that. That's why I thought it is not my duty.
But I think sir is not available. So I think sir
Okay.
is a senior person. You can. You have been
Okay,
the
right.
CSI
Okay.
national president also.
Because I thought it is
Fine, sir. It's a great gesture.
Dayasagar Rao or
They are not there in the. In
Vijay
this.
should do that. Okay, right.
Sir.
Right.
Okay, ECG X-ray. Will it help or not? That's
Sir,
it. Will the
ECG.
ECG and X-ray help you in sorting out the issues which you have raised?
Sir, there is LVH. There is
No, my
volume
question,
overload,
you
pressure
listen to
overload.
You listen to the question because we want to cut short the time. Okay. Do you think the ECG and X-ray will sort out the issues which we have discussed? Like which is the dominant lesion? What is the etiology of that? If so, which will you prefer, X-ray or ECG? Because
Sir,
Is
lesion
there any
is clear.
is there any
X-ray.
incremental value? Is
Of.
there any incremental value of ECG? None.
No, sir. No, sir.
So
Yeah.
go forward.
X-ray.
Sir, there are some information from the X-ray.
Yeah.
with regular things like there is cardiomegaly, LV type of.
Okay, fine. What is the additional information you have got?
Sir,
Most
upper right
likely-
border.
No. What is the most important things? You have got MR, AR, certain things you have got the straightforward answer. What is that?
Cardiomegaly.
Not that. That is there clinically. In the discussion, we have come to the lesion. We want to contribute to that. Either
Yes.
support or exclude. The
Sir,
aortic root. The
aortic root,
is
ascending aorta
dilated.
is aortic root and ascending aorta is dilated.
Yeah. So there is a disproportionate dilatation of the ascending aorta. Aortic root you can't see because it is masked by the cardiac cell. Aortic root actually is the sinuses. Up to the
Yes, sir.
sinotubular junction is the aortic root. This is the trunk or ascending aorta. The root you
Yes.
cannot see in an X-ray test of you because it will be masked by the cardiac cell. So there is a gross dilatation of the ascending aorta which you have picked up and we have discussed. What is the negative thing? Hemodynamic negative thing. So all the other things cardiomegaly you expect, you may expect some left atrial enlargement, all those things you expect. But what is the hemodynamic thing which you want to have? The pulmonary
PVH.
venous pressure and the pulmonary
PVH.
arterial pressure. Any
Yes, sir.
information?
Sir, there is no PVH, no
Now,
signs
the
of
problem
PVH.
is this X-ray is not good to assess the pulmonary vasculature. Because if you look
Yes.
at the X-ray exposure, this I don't know whether it is a portable or not. You find that the upper half, it is more exposed. It is darker. That will attenuate the vessels. To have the pulmonary vasculature, we have this standard exposure and better the standard big film is better than your digital. So the exposure is extremely important to assess the pulmonary vasculature. With this X-ray, I will not comment about the pulmonary vasculature. The only thing which I can say is the main pulmonary artery is not dilated because that region is flat or concave. It is not convex. So that's the
Yes,
only information I can have. You can't talk about the pulmonary vasculature, venous pressure, all those things. But definitely the information which is strongly contributing to our discussion is the dilated ascending aorta. That's my distinction.
And also right atrium also is dilated.
Yeah.
You can see below the ascending aorta, the right atrium also appears to be dilated.
Right.
And I agree with you. This is not a great X-ray to assess the pulmonary vasculature.
So the rest of the things you have, cardiomegaly we have. Left atrium we expect it. Only the size of the left atrium is a huge left atrium or not. I don't think it is a huge left atrium, but I think we should have better X-ray. Shall we go to the next thing, sir?
Yes, sir.
Yes, please.
Yes.
Sir, the echo, the first image is parasternal long axis view showing LALV dilated aortic root and RVOT. And then the second, we can see there is a significant aortic regurgitation. And there is some moderate MR in the parasternal long axis view.
We will not ask questions because this is not enough for you to answer our questions. But you should read. The questions will be on echo Doppler assessment of MR, aortic regurgitation, all the lesions. You should be very clear about that. And one thing what you have to do in practice is that things you should have a chart in your echo room because it is not easy to remember all these things. So we'll ask these questions. You should be ready with that because we don't want to spend time by asking this question because you have to answer that. Okay, fine. But we are interested in the mitral leaflet, the mitral annulus, the aorta, and the pulmonary artery pressure from the TR. Okay, these are the informations. As sir said, we want to know what is the mechanism of MR. We are discussing about annulus, the leaflets, the prolapse, which leaflets involved, is it what is the etiology of that mitral regurgitation, all those things. Okay, go ahead. Sir.
Sir, in the parasternal long axis view, we can see both AML and PML. PML appears to be appears to be restricted, and there is some minimal thickening of the PML. AML is moving normally, sir. And
now let us wait for the commissural fusion. Is there a commissural fusion or not? Because that is the hallmark of rheumatic mitral valve involvement. That you will see in the short axis.
Short axis.
But in this echo, just something is striking. Because something is striking.
It's a dilated aortic.
You want a clue?
Dilated aortic root?
No. What was the surgery done?
Sir, there is a hyperechoic hyperechoic in the aortic root, aortic annulus.
So the aortic annulus is hyperechoic, not the mitral annulus.
Yes,
Okay.
mitral.
So that is a striking
sir.
in that. The hyperechoic part of the aortic annulus is the most striking thing. So we were debating.
Yes, sir.
You are sure about aortic valve repair? Probably you might have seen the whole thing. Okay, now I am sure that they have done something for the aortic root. Okay, fine. Sir, Rao sir, because he is
The aortic
in echocardiogram.
regurgitation is posterior eccentric.
Posterior eccentric.
Posterior eccentric aortic regurgitation. So this is the one which can produce an Austin Flint murmur.
And this AR can be sometimes heard over the axilla because it strikes the posterior left ventricular wall and it can go up. Rarely AR can be heard even in the axilla. It is described. I read it recently. And this is the posterior jet striking the posterior wall of the left ventricle can be heard. That is not your initial answer. That's a final answer if you want to get a bonus mark. Okay. But this murmur by the echocardiogram is less likely to produce. I have to see the apical four-chamber view. As sir said, better heard on the right side. You should be careful. Okay. Next, sir said he wants to see the annulus or the, yes, the annulus. MR, you have to see what is,
We
is it
wanted
a
to see
single
the
jet or
commissural
multiple jet?
fusion. Commissural fusion.
The MR, sir, is it more than one jet in the mitral? Anyway, you have to have the dynamic, real dynamic picture, which we are not seeing. Okay, go ahead, Commissioner.
Sir, this is aortic root dimensions. And maximally aortic root ascending aorta diameter is 7.6 centimeters.
Yeah.
Which is very usually dilatation.
So this is, do you think this is annuloaortic ectasia?
Sorry, it can be annuloaortic
No,
ectasia.
at present not, because annulus is not dilated. Annuloaortic ectasia means the annulus also gets involved in that degeneration. So the annulus gets dilated, the aortic root and ascending aorta, predominantly the aortic root and the proximal ascending aorta. So you can't say annuloaortic ectasia with this. We don't know whether it was dilated earlier. Fine, go ahead.
Is it a bicuspid aortic valve or tricuspid aortic valve? Because
sir, in the I would like to comment that in the short axis view, sir.
Fine.
Okay, right.
Sir, this is a mode across the mitral wall showing anterior mitral leaflet fluttering, AML fluttering across the mitral wall of the AML.
And another thing
So
in
that
that is
there you also need to say whether it is a coarse flutter or fine flutter or pan-diastolic flutter or early diastolic flutter or early mid, or so that will tell you the duration of the aortic regurgitation.
seems
So
to be
to me,
almost a
it looks
pan-diastolic.
like
Am I right, sir?
on the screen it looks like early plus mid diastolic flutter.
Okay, maybe. And second thing is the AML excursion. I think you have to measure that. Is it limited or not? In severe AR, the early diastolic mitral excursion will be less because of the effect of the AR jet. Okay, fine. Go ahead. Annulus.
Sir, this is a LV functions appears to be grossly satisfactory, and coming to the short axis view of aorta, there is a it looks like a bicuspid aortic valve, sir. Two leaflets are seen, and also there is a dissection flap here. In the next photo, it is very clear.
You know the diagnosis. That is a problem. Because you have to be careful with that alone to say it is a dissection flap. That means you know the diagnosis. Because I am not convinced in that view that it's a dissection flap. There is something seen. If I say it is tri-leaflet with the asymmetric leaflets, there is a big sinus here. You can see something between 11 o'clock and 3 o'clock. Something is moving. You interpret it as dissection because you know the diagnosis. So that's a problem with you. Don't jump. Because you want to say dissection flap, you have to have multiple views. Okay, fine. Go ahead. Next. I was not sure. I was just debating whether it was a tri-leaflet or not.
You are able to see the coronary. You are able to see the coronary there, left coronary.
We can RCA.
So you should have made a mention of that. You are seeing up to the bifurcation of the left coronary.
Yes, sir.
Okay, go ahead.
And here we can see some part of the pulmonary artery, which is being compressed by the aorta.
Oh, you are drawing too many conclusions, but we take the important things. Now, it gives us an impression they have already done the case. We have discussed with sir. We are a good training. Because we are not concentrating on that now. We are concentrating on aorta. We get better views to comments, very good views to see what is happening. Maybe in Doppler and spectral trace. Okay, fine. Go ahead.
Sir, this is a color across the aortic short axis in short axis view across the aortic wall. There is a aortic regurgitation.
Yeah. Aortic
There is aortic
regurgitation. How many? Very difficult with single frozen images. Now you have to see there is a jet there. In certain views, how many jets? We don't know. Okay. Definitely there are multiple jets in that. Sir is a
Yes,
better
sir.
person.
You
Rao
could
sir.
look at the Doppler. What does the Doppler tell you?
Sir,
There is a Doppler strip there.
Yes,
Spectral
sir.
trace.
Sir,
Lowest one.
this is across the pulmonary walls, pulmonary artery.
Yeah, what does it tell you?
Sir, there is a gradient across the pulmonary wall. There is
How
a
much
gradient.
is the, how much is the
Gradient is 52 mm of H mercury, sir.
almost close to 60.
60, sir.
They have put it, sir. There is 52.86 is in the 98 is in that in the chart they have put. 52.
And then
Okay.
what about the PR?
Yeah.
Sir, PR end. So diastolic pressure in the PR is 19, sir. End diastolic pressure is end pressures are 2.23 meter per second. So it comes to around 19.9, around 20 mm of Hg.
Then what
early
about
diastolic?
mean PA pressure?
Mean PA pressures, it's coming around 3.5 meter per second, sir. Around.
Where is it
So
given?
what's the mean pressure?
So mean pressure, we have to calculate by using a formula, or else we can the early peak. Hello.
Yeah, that's right. You are right. That early diastolic peak.
Early diastolic peak will help us in calculating the
Yeah.
mean pressure with the formula 4 into early diastolic peak pressure plus right atrial pressure.
Okay.
4 V square, as usual.
Yes,
So it's
sir.
around 3 in this. And so 936 plus, so it will be something around 40 millimeters of mercury.
40, sir.
40. Okay, fine. Great.
Sir,
Now, what does it
here,
mean? Because you jump to the conclusion that this is compressing. If it is rheumatic, now you said it is a valvular gradient. So is this root compressing the aortic annulus? Because anatomically they are not at the right position. But there is a large aorta. What is it? It's a supra-inferior relation to the pulmonary annulus, which is at a higher level.
Sir, pulmonary annulus is at the higher level.
So you think that the dilated ascending aorta or the root is compressing the pulmonary annulus region.
Yes,
So
sir.
here we have to differentiate because we are discussing rheumatic. Whether this problem is pulmonary valve morphology, you have to look into. Because you can see the pulmonary valve. It looks normal. Is there any
Normal.
doming of that pulmonary valve?
No
Whatever
doming
you are
of the
saying,
pulmonary
it
wall.
is not thick because we have to concentrate on that. That is, you are seeing a gradient which is starting, and you can see that aliasing is starting at the pulmonary with the PISA at the pulmonary valve. So the gradient is at the pulmonary valve and it is dispersing after that. And the pulmonary annulus is relatively normal. Now what you have to say is what is the pulmonary valve like? At least in the first 2 frames, I think the pulmonary valve seems to be of normal thickness. Okay, so it could be a compression by that aortic root or ascending aortic root dilatation. Sir, you agree with that?
That is one possibility, but still you cannot rule out in a multivalvular heart disease an associated pulmonary valve disease.
Next.
Even if it is Marfan's, still pulmonary valve could be involved in Marfan's as well.
Sir, not clear, sir. Your voice is not audible, sir.
Am I muted? No, I'm not muted.
Okay.
Can you hear me now?
Yeah.
Yeah. It could be a dysplastic pulmonary valve in the Marfan's, or a prolapse of the pulmonary valve. So they can produce a primary pulmonary valve disease in Marfan's. But there is no evidence of prolapse of the pulmonary valve from the images that are available. But everything is starting at the pulmonary valve level. So I suppose that possibly there is something wrong with the valve itself rather than only the compression. So I'm not convinced that this is due to compression, but maybe more because of possibly something wrong with the pulmonary valve itself.
Okay, sir.
That's what I think. Go ahead,
Go
Dr.
ahead.
Mark.
Next one. I think you are
Sir,
got,
apical-
you are following our discussion.
Yes, sir.
There is a RVO flow obstruction at the valvular level. Whether
Yes,
the
sir.
valve is abnormal or the annulus is compressed, for that you have to have a better delineation of the aortic valve by echocardiogram or by other investigations. Okay, fine. Based on
This is
go ahead.
apical fortune.
Yeah. Fine.
Go back.
Sir, this is inflow across the mitral wall.
Yeah.
Not showing. And E by E prime is 24, sir. LV EDP is significantly elevated.
E by E prime. It has limitations in presence of significant MR. You know that.
MR, yes, sir. Yes, sir.
MR E will be markedly elevated. So
Elevated.
E by E prime has significant limitations in assessing the LA pressure in presence of severe MR.
MR.
That should be careful. Okay. So here we are interested in the mechanism of MR. Do you think the mitral valve is myxomatous or not? Is it primary MR or secondary MR? Basic lesion could be aortic with LV dilatation, with the annular dilatation and the mitral valve structure. Do you think it is a myxomatous valve? What about the subvalvular apparatus? Is it rheumatic? Because we can get some information. Maybe we have to do transesophageal 3D, but you can see the leaflets to me didn't look like myxomatous. The chordae are not thickened. They are not lengthened. There is no definite prolapse, at least probably a minor prolapse of the PMN. I think Rao sir will be better person.
I will add that you can see a cooptation failure. Mitral valve, both leaflet cooptation failure. You can see that.
And the jet was central. Am I right? In the apical four chamber, it was a central
Yeah,
jet.
yeah. Another thing is there probably may be a loose chordae. Posterior leaflet, there is a chordae which is hanging from that. Maybe there was a minor chordal rupture.
Sir, posterior mitral leaflet was not moving. There was a restricted posterior mitral leaflet movement, which we have to think in terms of rheumatic also.
No, not necessarily. The only hallmark of rheumatic is a commissural fusion, which you have not shown so far. Short axis of the mitral valve.
Second, we are deviating a little
Sir,
from rheumatic after seeing that aortic root, all those things. So we have to consider a non-rheumatic also. So far to me and probably to sir also, there is no definite evidence of a rheumatic mitral valve involvement. So we have to go for further imaging. Now from this, we are concentrating for the TR. What do you think of the TR?
TR is mild to moderate TR, sir.
We are interested in the pressure.
Sir,
Always systolic pressure from the TR jet.
Sir, I didn't take the TR jet. I didn't get
fine.
that.
AR, we are not very much concerned because it is severe AR. But we are interested in two things. One is, what is the valve like? What is the dissection which we have discussed? There is one thing. Are you convinced about the dissection in any of the images?
Sir, we have done further investigations.
No, we not. That's why in the beginning itself I said, when you percuss out the second and third intercourse space, I told you that you know the diagnosis. In the examination, you should be careful. Because many times we have the diagnosis. That's very clear. Whether you are in your parent institution or elsewhere, you have the diagnosis. You are DM. Am I right?
Yes.
So your examination is in Pushpagiri itself. Am I right?
Yes, sir.
Then
Yes, sir.
obviously you will have the diagnosis because we got the diagnosis for our MD and DM. But it doesn't matter. We are not interested in the diagnosis. So you'll get the whole information before you appear in the examination. But you have to use it very judiciously and very intelligently. Okay? Don't discuss based on the diagnosis which you have. That happens quite often. The second writing course place was the clear evidence that you know the diagnosis. Okay. Fine. And second thing you state about the status post aortic valve surgery, repair. There again, we got the impression that we got the clue that you know the diagnosis. So such things you should keep as reserved. Okay, when you are discussing for the examination. Fine.
Yes, sir.
Go ahead. So from the echo, because for us, echo is a very useful tool to pick up dissection. Here you are seeing aortic regurgitation. Next slide. Jet
Sir, here
direction,
with the
as sir said, what was
Hello.
the jet direction? As Rao sir was telling, the jet direction, previous one. Okay, fine, go ahead. Sir, what about the jet direction, sir? You are convinced it is a posteriorly directed jet, but we don't have that picture fully.
Yeah, we don't.
Yeah, sir, it is
There is
coming from the
aortic root.
septum.
He is trying to show the aortic root. Probably he is
Yes.
imaging from the right upper parasternal area.
And it is not directed towards the septum.
Yeah.
It is going, as sir said, it is going more posteriorly or to the AV cavity.
Okay, sir.
Okay, fine. Or
Sir,
there will be multiple jets. Go ahead.
there is a hollow, sir. We can see a red jet. This is a echo suprasternal view. We can see the diastolic flow reversal in the descending thoracic aorta.
Yeah. So, sir will ask you which is the most useful thing to assess the severity of AR. That is sir's favorite question. In suprasternal view, what is the data needed?
Diagnosis murmur, hollow diastolic flow reversal in descending thoracic.
Yeah. Here itself there is something. If the end diastolic gradient is
End diastolic gradient. It
end
should
diastolic gradient in this reversal is more than, I think it
be
is
15 centimeter per second.
Is it 15
15 to 20 centimeter per second.
Yeah, that's right.
20.
Yeah, right. Now, is there a dissection?
Sir, there is no dissection in the descending thoracic aorta.
No, we are looking for dissection in the ascending aorta because in the parasternal long axis, you said there is a dissection and you have the pulsation and percussion in the second and right intercostal space. You should have imaged the aorta from the second and third right intercostal space and from the suprasternum because you could percuss it out and you have seen a huge aorta there. So you should have scanned from the right upper sternal edge and suprasternum for the ascending aorta because in our experience, we have found that the aortic dissection proximal can be easily picked up by echocardiogram two-dimensional. That is our experience. I am sure others also will agree with that. Doubtful cases, we have to proceed.
That's right. We also do sometimes turn them to the right lateral position and then image from the right parasternal area. That is one of the good positions to pick up ascending aorta dissections transthoracic.
Okay. Next.
Sir, this is a CT aortogram.
What we want is, did you try TE? Because
Sir,
we want to know, you are thinking in terms of dissection. Was it acute dissection you are considering? Because you go for emergency, this thing, or will you go for TE? Because you get so many information from TE. We are interested in the mitral valve.
Yes, sir.
We are interested in the mitral valve. And we can see the aorta also. Okay, yes, unless it is an emergency aortic dissection, which you are not convinced, I would have gone for a 3D TE. Okay, CT, go ahead with the CT. Now, my point is, this is because you know the case sequence. If you were not aware of that, you would have asked for TE, because I am not suspecting an acute dissection. Okay, that's the point. Okay, go ahead. Sir, you agree or disagree?
Yeah, I completely agree.
Yeah. So that's the problem of seeing the case or knowing the case. Okay. Because you are better in interpreting TE rather than CT. Am I right, Manjula?
Yes, sir. Yes, sir.
You want to,
CT, you are at the mercy of the radiologist,
yeah.
who may or may not be good enough to report a cardiac CT. Frequently, they are not.
Shall I proceed, sir?
Yes.
This is a CT image. Showing the arch.
Don't entertain.
Here we can see the dilated ascending aorta. This is dilated ascending aorta compressing on the pulmonary artery as well as right pulmonary artery.
Yes.
And you can see a dissection flap here.
Where?
Sir, here.
There is in the upper part of the ascending aorta.
Yes, sir.
Okay.
Near the root. I'm playing it back.
Not near the root. Let me see. Okay. You are playing left atrium. Okay. A flap there. Let me see that.
I'll play again, sir.
Yeah. You are looking at the flap or the aortic valve, the leaflet there. Come slow. It is beyond the. Now, go ahead.
Again, I'm playing.
Yeah. Okay. Okay. Fine. This is at the annular level.
Annular level. Yes, sir.
Okay. I said these are the leaflets because there are two things like this.
Yeah. It looks like a aortic valve leaflet.
But we are at the mercy of the imagologist. That we agree. But to me, it looked like aortic leaflets. Because the flap usually will be horizontal, it's a single thing.
No, that is what he is showing as flap is actually aortic valve leaflet.
Yeah.
No, actually, the aortic valve is slightly at a lower level than the flap. If you see carefully, you will first see the flap, and then as you go down, you see the aortic valve.
Okay, sir may be better. Sirs, we accepted.
Now you see in the previous frame, you can see the dissector flap.
Okay.
And then subsequently only the aortic valve is seen.
Is it because that was the opened up aortic valve leaflet? Because what we are seeing here is the closed leaflets. That is called like the club-shaped thing. When the aortic valve leaflet is open,
too high for the open aortic valve.
No, I'm not just not debating or contradicting.
Because the size of the aorta at that level is very huge, very big. So it must be the dilated ascending aorta.
Fine. Because the aorta till proximally was okay, fine, sir. We will go their report. Now, sir, we go with the report of Manjaran sir and the imagologist. Okay. It's a very small flap, but I'm not sure what you have shown in the echo is same or not. Fine, doesn't matter. But two things are there. What is the pulmonary valve like? That is Rauser's question. Now, in the examination, we are not disagreeing with the diagnosis. Certain queries have been raised during the discussion. Have you answered these queries? That is what you have to tell in the examination. We are not interested in what is the final diagnosis with the department or overall assessment by the whole team has made. As a student, have we answered our doubts?
Sir, still with respect to mitral valve, it's a question whether what is the etiology of mitral regurgitation here.
Okay, fine.
Second thing.
So you would have preferred a transesophageal echocardiography prior to. We are not questioning the attitude or the approach of the team. In the examination, we prefer a transesophageal echography because it will give more information. And then obviously you go for a CT if you have seen it, because it's a small flap concentrating on a small area. That flap was not extending upwards. It was a curvilinear flap, which was a small area seen just above the aortic annulus or things. That's all. Fine.
Actually, Sudhaiman, I was thinking whether this flap was raised as during surgery as a surgical trauma.
Okay, fine, sir. That's fine.
So I was not thinking that this could be a usual dissection, but it could be some flap which was raised as a surgical trauma when the aortic valve was repaired about 20 years ago.
Okay. But the CT
so we
should
also,
answer the annulus.
If it is dissection on echo or CT or MRI. Other information also is required, like for example, where is the entry point for the dissection? Is there an exit point? And what is the status of the false lumen? And then the flap, whether that is prolapsing into the aortic valve orifice, and that is responsible for the aortic regurgitation. If that is so, that is easier to treat surgically. And then whether this dissection has gone up to, the other levels as well.
No,
So these are some of the things which the surgeon would like to know. We also would like to know.
no, Krishnaraju, this was actually, we thought the dissection would have happened about 20 years ago during the time of dissection and during the time of the repair of the aortic valve. So the usual pattern of the aortic dissection that you see in echocardiography, we are not expecting. So we just try to explain, we saw a flap, so we try to give an explanation, that's all. We are not arguing that this is a classical dissection, an acute dissection. This is a flap which we saw during echo examination, and we wanted to give an interpretation. And the interpretation was that quite possible that this might have happened as a trauma during surgery, and it may not be a big problem.
It's a localized small area only. Am I
Yes,
right?
yes. It's
But
a small area.
the CT, you would have looked for that annulus. Where was the ring put? Was it mentioned? Because we are discussing about the surgery. What was the surgery done? No, in the echocardiogram, we found that the root was hyperechoic, suggesting a possibility. What was the surgery done at that time? Okay.
Aortic wall repair.
No.
It was aortic.
Pardon?
It was aortic wall repair, sir.
It was aortic valve repair.
Yes,
Okay.
sir.
No, it is very intriguing to me why the surgeon decided to an aortic valve repair
Yeah.
with multi-valve disease at that point in time. And all of us know the failure rate of aortic valve repair is very, very high. And particularly with regard to this kind of multi-valve lesion, etc. So it is very intriguing to know.
Sir, I feel that at that time, it could have been aneloaortic ectasia. Okay. And aneloaortic ectasia, we find that in this case, the annulus as such is relatively small. And there was echogenic thing. So the aneloaortic ectasia, they might have put an aortic root ring to reduce that aortic annulus. Because ascending aorta, they didn't want to involve because it is not easy to tackle that aortic pathology. So I still feel that it was an aneloaortic ectasia with a dilated aortic annulus, and the annulus was repaired, which resulted in a turbulence which might have further produced the aortic root dilatation. That is one of my possibilities. And the dissection which we have seen as a small flap, it is a relatively benign thing. And I also now support Manuran sir's view that it could have been a post-operative damage to the endothelium which has occurred. That would be easier rather than an extensive dissection.
Agreed about that.
And also, I think we do not have any clue what was the clinical status 20 or 25 years ago.
Yeah.
Quite possible that there may be only a very mild mitral regurgitation, and the significant lesion would have been only aortic regurgitation, and that is why the surgeon attempted. And the patient has lost all the records, and we don't have any records from the patient. We actually concluded that most likely it must have been aortic valve repair, as Sudhimar has rightly said, looking at the annulus and all. Patient has lost the records. He did not know which valve is repaired and all those things. Only thing he knows is that the surgeon said you have to undergo another valve replacement, and this is a more risky procedure. And the surgeon himself actually dissuaded this patient from undergoing the procedure.
So there is one comment there. Is it possible that this patient had this repair in Mangalore?
No, not in Mangalore.
Manipal Hospital.
I am not going to the hospital, but it was done in Chennai.
Sir, can we go to the CT once again to see whether there was an aortic annular ring? May not be for us, for the imagologist, because annulus is only 2.8 centimeters. In an aortic root dilatation like this, annulus should be dilated. Whatever we are seeing, In a root dilatation of any cause, the annulus also will be large. Here it's only 8 centimeters. Now huge ascending aorta, coming down it is becoming narrow. That is the thing which sir has seen. Now that is the region of the valve. Now you have to come down to see. We are not good in that. Whether you can come down, oh, I'm not sure. I'm not.
No, Swayamar, see, it is not a must that aortic annulus should be dilated in all patients with ascending aortic aneurysm, especially in bicuspid aortic valve, the type of aneurysm that you can, the aortopathy, you can have ascending aorta grossly dilated and the aortic annulus can be sometimes normal. So that is well described.
I agree with sir. Instead of going for an aortic valve repair, more likely annulus is statistically more likely. That's all what I am telling.
I know, because we do not know what has been done to him during the surgical procedure.
So we had a surgeon, visiting surgeon, Dr. Satpathy, is a cardiovascular surgeon.
I know, Satpathy and me were together in New Zealand. I know him very well.
So he was the adult department of cardiac surgery in Manipal Hospital.
Yes, Mangalore, Manipal, yes.
Friend of mine, and he used to visit my hospital, and he was very good in repairs. So he did 5 mitral valve repairs and 3 aortic valve repairs for a period of 1 week in my hospital in early 90s.
Oh.
I followed up those patients. All the 3 aortic valve repairs up to 2 or 3 years were doing very fine. There was not even a minimal leak of the aortic valve. His mitral valve repairs were also good except for one patient. So he was very good in these 2 valve repair. He was very fond of doing aortic valve repairs those days. It is almost now something like 1994, more than 30 years back. That was Satpathy. He had his own techniques. In fact, it's called Satpathy's technique of repair.
Okay, sir. You are exceeding time, sir.
Oh, by more than 1 hour.
No, only 15 minutes. We are supposed to end at 1 o'clock.
No, you are supposed to be finish. And I am supposed to give a small lecture. I think I will skip it.
12:30, sir. That's why I was remaining, sir, about the time factor.
No, but I thought, our student can get a good exposure to the way in which the examiners can ask questions and all those. That is why I didn't want to interfere, because this I wanted to get him. He's appearing in 2 months' time, so I wanted him to get a good exposure to another group, how the questions are asked, how they are analyzed and all.
But analysis in this case, I think it's good that this is a very unusual case. Seldom we have discussed this much extent of aortic root, possible dissection, annulus, all those things. I think I really enjoyed the whole discussion. I really enjoyed the case. And the student, I think he did extremely well. Certain areas you have to modify, certain presentation you have to modify, but don't be taken away by the diagnosis which you have. You will be take simple things, and the important things should be highlighted. Okay, there are certain lacking in your presentation which we have highlighted. You have done fairly well. You have answered many questions which are routinely asked. Certain questions from our side were difficult. One thing, you answer to the question, you study the question, especially Rao sir was asking some question. You study that question and analyze that and then answer according to that. Certain areas where you are not sure, you can say, I'm not sure. But overall, your presentation has been acceptable and good. Obviously, Maniran sir will call me and ask. So I straight said that this is nothing confidential. This is my real assessment. There are areas of improvement, but more important is limitations you should know. And you should not be taken away by the diagnosis which you have. Because that second and third intercostal percussion, I think you could have avoided because very difficult. Then I knew that you got that. Then second zone, you should be a little more careful. The P2 intensity. So I think overall it's okay. Sir, overall, I think you should not have any problem in the examination.
See, what Swayamar was telling, I had been repeatedly training him that whenever a question is asked, listen to the question, analyze, and then only answer. Yes, sometimes the answer is when as soon as the question comes. So I used to tell him that better you should listen to the question, understand the question, and then answer to the question. I think yes, he's now he's also is going in that direction, so that the questions are being answered after analysis. He has steadily improved. And I also told him that many times when you go for the examination, you may get a clue to the diagnosis, but you should use it intelligently.
Yeah, always, sir. If it's an internal from this thing, they know the diagnosis because
Yes,
the
yes.
previous day they go to the postgraduate tell these are the cases kept. Even that's a pattern. So diagnosis they know. That's a problem with them in the examination. Rao sir has left, I think.
No, there was a call coming and it's okay. So I think I agree with your final comments, but you have to be more economical with your language of presentation and need to be more appropriate in your expression. And you should also know what can be made out and what cannot be made out. So don't get into wrong areas because you will get caught there. So once you are caught there in the wrong area, more questions will follow, and then you will be going right into the pit. So, and the hallmark of a consultant, when Manjunath passes through his DM cardiology, he is going to be a consultant. So, what is the hallmark of a consultant is not to get biased. So, for example, tomorrow you get a diagnosis of something from Professor Manjuran or Professor Sudhay Kumar. Don't blindly accept it. Use your mind, use your analysis, right? So then only you deduce. Just because Professor Manjuran said something, or Sudhay has said something, or I said, or somebody else had given a diagnosis, you don't have to go by that. When a patient comes to you for a second opinion, he wants your independent opinion, right? So you are under no obligation to endorse the opinion of the referring cardiologist or whoever was the cardiologist before you. So that is the hallmark of a consultant. You should use your own techniques, your own analysis, your own language, and not go get biased at all. That's extremely important, not only for cardiology, any specialty in medicine. So don't get biased.
Thank you,
sir. One word. My final contribution to what sir has said in your practice. You may object, you may disagree, but with respect and diplomatically only you disagree with your colleague's diagnosis. That's very important. You should not say that that diagnosis is wrong. You should be very diplomatic with respect. You should put that your opinion in a very diplomatic, without say contradicting grossly with your colleague, whether it is senior or junior, in front of the patient. You should go with the patient. There is no doubt about that. You should be for the patient, but you should not contradict your colleague strongly. It should be in a very diplomatic fashion. You can put double negatives and say, sir, put it like that. It may be right, but I personally feel it may not be. I would like to discuss. I want some time, and then I will inform you. That's a thing which you have to have. Okay.
Let me thank Sudhay Kumar and Krishnaraju for an excellent discussion. But then this patient, actually, we referred him for surgery, and he underwent a modified ventral procedure. And he had a bicuspid aortic valve with aortopathy, and mitral valve was repaired. And his
what is that flap? That flap, any idea, sir? Flap?
Well, there was no comment. Actually, I wanted to get the specimen for pathological examination, but the surgeon actually threw it in the bucket. So actually, and patient is doing extremely well. The heart size has come down. The mitral regurgitation has actually practically become nil, and the aortic the turbulence in the pulmonary artery has significantly come down. Some amount is still remaining. So overall, he has done extremely well. He's doing very well, and thanks to Jaykumar. Jaykumar has done the procedure.
Oh, Jaykumar has done the procedure. Okay, great. Should be appreciated.
Yes, I think it was because I was very skeptical. The patient's relatives were very skeptical. Then I told them that this is the only way. Otherwise, the aorta will rupture and you will collapse and die. So he agreed on it, and then Jaykumar did a wonderful job, and he's doing extremely well. He did about a year ago. This is a patient about a year ago. He is doing very well. The heart size has come down. He's leading a normal life. He has gone back to his job and is practically, I would say that class 1 symptomatic.
Wonderful. Wonderful, sir.
So there will be additional questions if it is a bicuspid aortopathy. The student, suppose the final diagnosis after the investigations is given as bicuspid aortopathy, and there may be many questions. What are the types of bicuspid valve? And then why does it produce aortopathy? Can aortopathy be present independent of the bicuspid valve? And what is the reason why they are so much associated? What is the natural history of bicuspid aortic valve? What is the natural history of bicuspid aortopathy? So, and what is the medical management? And of course, the surgical management. These will be automatic questions once the cat is out of the bag.
Actually, I was supposed to talk about all these things, but
we did not allow you.
I have prepared all these things. The question that you asked, type of bicuspid aortic valve and how it is identified, and in one type of bicuspid aortic valve, where will be the aneurysm, in another type, where will be the aneurysm, and all those things, and what is the difference between trileaflet, the three-cusp bicuspid aortic valve and two-cusp aortic valve. All those things and actually I had prepared. But then I wanted this discussion to go on mostly because I found that only 4 of us are there. There are no participants, nobody. So I thought the candidate will be benefited by the expertise and the questioning of both of you. So that is why I thought rather than my presenting.
Manjuran, participants number 4 shown here is not the total number. Many of them will be following through either Facebook or YouTube.
Oh, that may be right.
So
Yeah.
participant 6 is not that. That is what we are here. There is a separate is there. The people listening is separate. I think a site or a link.
There will be many more on YouTube. The
Yeah,
students
and sir, this 6
probably
is we people 6. There is special for the faculty.
yeah,
This link.
that's right.
Now, my final comment, in any bicuspid valve, rule out coarctation, which we miss. There is a thing. It has happened. Because we'll be concentrating on this thing and we miss coarctation. Especially if there is AR, we miss coarctation. I think that's all my comment. Fine, sir.
Okay,
Okay.
I think I will close at this level, and thank you, both of you. I think it has been a wonderful experience for our candidate, and I also could understand the type of questioning, and we will try to tune the training of our candidate accordingly. Thank you. Thank you.
Okay, thank you very much.
Thank you so much.
Thank you.
Thank you. All the best, Dr. Manjunath, for
Thank you,
your
sir.
examination.
Thank you so
sir.
much.
Nice to see Rao sir after a long time. Manjaran sir, we are seeing and interacting frequently. Okay.
Thank you.
Okay, see you next sometime later. Okay, wish you the very best, Manjunath.
Thank you, sir.
Bye-bye.
Technology team, we are stopping, closing.
Yeah.
Recording stopped.